Welcome to the GFY Podcast, a podcast by healthcare professionals providing healthcare professionals providing insight. Man, I can't even do it right today, huh?
I know. No, I know.
Nice. Go fix yourself. Podcast hosted by me, Michael Stant, and Michael Bruno. Although we're healthcare providers, we're not you're a healthcare provider. We'll discuss general health interventions in this podcast, but you should not take that as health advice that works in every situation. Before doing anything on your own or making any lifestyle changes, please consult with your own physician. This podcast and views from this podcast are separate from our full-time jobs and our own opinions. If you're enjoying the GFY podcast, please leave us a review on your listening platform and or subscribe to our podcast at YouTube. Links to our show can be found in the show notes on any platform that you're listening to. Today, we have Kathleen Criss on Blue Hen, UDAT 2016, University of Delaware 2016. Kathleen, if you want to give us a quick rundown on where you've been, where you're at now, what your interests are.
Yeah, roll heads. UDAT 2016 reunion coming up on our
10-year reunion. Stay tuned.
I don't say that. It makes me feel old. I don't like that at all. 10 years since college? Jesus.
Yeah, that's crazy. So I did my undergraduate in athletic training at University of Delaware, and then I actually took a gap year, and then I knew from the beginning I wanted to go into physical therapy, so after my gap year, returned to University of Delaware for PT school, and then moved down to Maryland and have been working for outpatient for a hospital system out here ever since. Pretty much my course.
Yes. And I know because the Olympics are top of mind for me. I'm seeing all that stuff. Tell us about the sport you pursued while you were in college.
Yeah, I was a figure skater for 18 years. Started when I was 4. I would say I was competitive light in that I trained to compete, but I was never a top level national, international type skater. And then University of Delaware was the only college that I applied to that continuing skating would be even an option. And I knew I wanted to go there pretty early on. And I took freshman year, I did not. The University of Delaware has a really successful collegiate figure skating team. They have 2. They have a synchro team, which is when you have the group of skaters all skating together on the ice, and then they have a figure skating team, which I say is almost like gymnastics or swimming. So it's still individual figure skating. Everyone's doing their individual events, and when you compete, the score you get in that event contributes points to your school's team. And so I took freshman year to kind of test out the waters in terms of being an athletic training interest, which obviously a very high demand major, and continuing to train or kind of still do skating in this new format, and between myself figuring it out and also talking with AT program Dan and good old Dan and Dr. K, figured that it would be doable and that people have done it before. And so sophomore, junior, and senior year, I competed for Delaware's figure skating team along with Mikey's wife.
Shout out for me.
And then kind of I pretty much once I graduated, I stopped skating. I kind of transitioned into coaching. I taught all the littles how to skate in the learn to skate program, and then COVID rinks shut down, and I kind of let my coaching certification expire and haven't done it yet. But I will say all of this buzz with skating is kind of giving me the itch again. I don't know. I might get my coaching certification again. We'll see.
That kid, they call him the quad god, right? He's the same kid who did the backflip.
In his programs, he has backflip.
So you can, I literally only know about figure skating through Instagram reels and what I see on TV. So you can tell me if this is real or not. But someone said that backflip move was illegal because it was so dangerous. And he was just saying, I don't care, and sent it. Is that true?
So it's legal now. So he's not doing it illegally. The backflip has been creating a lot of conversation lately, because a lot of people, I mean, just social media, right? Like everyone has to say something, everybody has to kind of nitpick everything. And so headlines about him being like the first person to do a backflip in competition are getting nitpicked and torn apart, and somewhat rightly so. He's not the first person to do a backflip. He's the first person to do it legally. Um, there, I actually believe, so I would have thought there was a French skater by the name of Surya Bonali who was a high-level skater, international competitor when I was little, sometime in the, like, maybe mid to late 90s, early 2000s. I don't 100% remember. And she could do a backflip, and she actually could do a backflip and land it on one leg and then even do another jump out of it. It was incredible. And I didn't realize this, but the backflip had already been deemed illegal from another man, like 20 years ago had done one, and I think after he did it is when it became illegal. I'm not 100% sure on that, but that's what I have learned recently. And so she had really tested the waters, and there was one competition. I also can't remember if it was actually the Olympics at this point, but there was one like really big competition, and she was pretty much already out of medal contention. And so she had been told, like, you can't do this backflip, and she decided to do it anyway because, like, she loved skating and she wanted to showcase what she could do, and she already knew that she was out of medal contention. And so um she did it anyway. And so her story is a really cool one, just to kind of give people some of like the background of the backflip and figure skating. It's a little bit of like a she walked, so Ilya could run. But yes, he is the first one who's doing it now that so in general, over the past couple of years, more like acrobatic type movements have become not only legal but like point earners, or point boosters in skating. So you'll see a lot more people doing like cartwheels or one-handed cartwheels on the ice, or in and out of spins, or even within like footwork sequences. They're doing these more acrobatic, even almost like martial arts type kick jump type movements in skating, which it's cool to see. Everything has to keep evolving and kind of evolving with the times, and so that is where things are going lately, and people are rising to the occasion.
So does the backflip actually count for points? My understanding was like he just kind of does it to do it.
I don't know the specifics. I have been so removed from like the rules of figure skating that I don't know the specifics on if his backflip counts for any, like, it's not an element that has a point value. But if he's doing it within a step sequence or something like that, it may be something that kind of contributes to a higher level. So like figure skating has elements like the jumps that are worth a certain number of points in and of themselves, whereas like the spins and footwork sequences, they're graded on levels of difficulty, and those levels are still worth points, but you can have like a level 1, a level 2, a level 3, a level 4. And so, like I said, I'm not 100% sure, but a backflip or an acrobatic movement might be one of the like things that you could do to increase your level of difficulty of an element, of like a footwork sequence or something.
So obviously you're down into the weeds of figure skating. Is why I got fully into it. So kind of based on all your experience and all that, you're an outpatient physical therapy setting now. Kind of talk about how those experiences you have, that knowledge you have, and how you kind of apply some of that stuff to your patients that you deal with now.
Gosh, I think my background in figure skating applies to everything I do in life, period. I think with physical therapy, the big edge that figure skating gets me, number one, like, so technically in my clinic, I do somewhat specialize in sports and performing arts, but we are still a community and also like a hospital system clinic. So I still see a lot of like general population, and especially based off of kind of like what my hospital sees, I get a lot of international, a lot of like medically complex patients. So my life of figure skating has been such that, so I'm from New Jersey. I grew up in New Jersey. I trained in New Jersey for the majority of my life, but there was a subset of time for a few years that my family and I actually moved out to California for skating to train, and we were training at an international training center. And so there were skaters. There were United, like US really elite skaters who were training at this center. But we also would get a team from Mexico every summer, a team from Japan every summer, a team from Italy would come out. We had skaters from all across the world coming over to train at this rink. In the summertime, the coaches and even skaters who have just moved out to California because this rink was kind of like a hot spot for skating. So we had skaters who represented Armenia and Russia and just a bunch of other countries. So I was surrounded by people of all ages, people of all from different countries, a bunch of different language. I can speak like a tiny little bit of a lot of languages. And so really just understanding other people, being able, like, I feel like I am someone who can almost connect in some way to everyone that walks into like my door. Also right now it's fun to talk about because a lot of people don't exactly advertise that I was a figure skater. So like when I talk about it now, it's just a fun talking point. But yeah, just in general, I think that's one of my like superpowers, I feel like, is that doesn't matter who you are, where you're from, what you've done in life. If you're older than me, if you're younger than me, I typically can find something that like we can connect on. And I really credit that to figure skating. I have worked with a lot of people who like come from like countries that are in turmoil. And so like same thing now. We have a lot of people who are coming from places that are in turmoil, or they're coming to the US for better medical care. And so being able to kind of relate to them because I have seen it in my life. This is not some like crazy thing to me. And like using interpreter services or having like language barriers, like that's something that I already have experience with in life. And so putting that into like my professional work, I feel like was an easier transition than it is for some people.
I like it. I mean, I always say communication is key. So like sounds like you have some added layers of complexity to that. So being able to connect with someone who might not be their first language, might be coming from a really tough situation, and still make them feel comfortable and at home so that they can, like actually make progress in like what they're coming in for. I think that's a huge part of, I always said this when I was in chiropractic school, like my class was tiny, but even in that small class, it's like, I would look at some people just had no like bedside manner, personal skills and stuff. And I was like,
Yeah.
how are you, like, I'm not saying like you get A's or you get S. Like, no, I'm not even saying like, yeah, you as a person, how are you going to be remotely like, how are you going to be able to communicate? You can't communicate with me. And I'm like, I don't know what you're trying to learn. That's crazy.
Well, then you go and talk to people who are very rightly frustrated with the medical system, and then they describe their appointment, and it's like, oh yeah, because people are going into health. There's a lot of people, and this is a systemic issue, right? This is not at the fault of the healthcare providers. It's not at the fault of the patients. This is very much a systemic issue. I will die on that hill that a lot of our healthcare problems are systemic, and like patient and provider really like to go at it. And it's like we have a common enemy. We're not enemies.
Right.
But the communication bit is so hard. Again, I work with like sports, and I work with a lot of post-op, and I am very lucky. I get access to a lot of patients preoperatively, which should be gold standard, but it's not fully the standard of care everywhere. And I have 45 minutes one-on-one with my patients. The surgeons are seeing patients every 15 minutes. There's no way they have the time to get every nuanced bit of information to the patient in a way that they can like fully digest it and understand it and ask follow-up questions. Like it's not possible. And again, it's not their fault. The physicians are given this like quota of patients to see. They don't have the time to fully communicate. And so I know there's physical benefits to prehab, but I think that education and communication piece is just as, if not more important for patients to understand like post-operative journey than just the actual physical benefits.
Oh yeah.
Being able to like set expectations because they can't get them, and being able to, I do a lot of myth busting in my office, especially again in the social media era. There are a lot of mouths talking on the internet.
Yeah.
And so doing a lot of myth busting, both from like social media things or even from like current, providers who are still giving out kind of outdated information, or they're talking, I wouldn't say outside of their scope, but outside of their lane. Um, I don't mean to rat on surgeons. I've got great relationships with the surgeons that I work with, but I think this is a common one of, getting patients who come in saying like, yeah, they told me I'd be back to this in 3 months, 6 months, whatever. And I'd be like, okay. So the way that I word it now is like, it's kind of like two parents. You have your surgeon parent and you have your rehab parent. And like, we look at things from different perspectives. They're looking at tissue healing and when it's safe to do things from tissue healing. I'm looking at your performance, and are you showing a level of performance that can support the activity that you're trying to do? Both parents have to say yes. This is not oh, mom told me no, maybe dad will say yes. Both parents have to agree that you are ready to do the thing. And oftentimes, I mean, I've had like people, surgeons may not fully, or other providers, again, not necessarily the surgeons, other providers may not fully understand like the scope of activity that certain people are doing. I'm going to be having my own surgery in a few weeks, and like talking about post-operative restrictions and everything, and like how long am I going to be out of work. I don't do a typical desk job. No, I'm not the athletes that I'm treating, but I'm still lifting the weights. I'm still doing the testing. Like, I'm exerting a lot of force. And so my return to work timeline should look different than someone who does a desk job. And I don't know that has always been considered. I feel like I went way off on a tangent.
No, you're good. Even like you kind of pointed it out, right? A surgeon, and this is why I always surgeon, doctor, whoever it is, you kind of just said it. They talk to you for 15 minutes. There's no chance they actually fully grasp what everything is that they're doing at that time point, and that's where you're able to step in and be like,
Yeah.
I fully grasp it. And it goes both ways. Is it letting them do more sooner, or is it stopping them from doing anything? Because I like, you see it both ways, just depending on who they see.
Yeah. And some of it is on us. Like, I think, I can't talk to all rehab providers, but like, if we're seeing something, I think we could do maybe a better job of keeping the doctors in the know so that they have it in their brain of, oh, you know what? I'm getting a lot of emails that like these people aren't ready to run until 4 months instead of 3 months, right? Or like that. So then it's in the front of their brain a little bit more. Maybe I should be changing how I word these things to patients. I've done it. When I talk about like post-operative red flags to patients, so I'm talking about like signs and symptoms like DVD and pulmonary embolism. I had learned that there were quite a few people that I learned their like symptoms of PE was like back pain that either like went through or like wrapped around, and I didn't remember that being kind of a telltale sign of symptoms. So, like, I changed my wording to include that. Like, hey, I've also heard people experience this symptom because that's what I was experiencing clinically, which is also part of the evidence-based practice.
Yeah.
Right, is clinical experience. And so I don't know that everybody is taking that clinical experience into their like education component of treating patients. I also think, again, this is part of like a stay in your lane, which is that could be a whole other topic that I'm super passionate about. Of like, I don't tell other providers how to do their job. So like they couldn't, and again, this is not this is not a, so don't tell me how to do my own, but this is also like a, but you don't do my job. So you couldn't possibly know what the full rehab process of the surgery that you do looks like.
Mhm.
You know, how many doctors and surgeons have I shadowed? How many have shadowed me?
Mhm.
Something that like my I think my department is actually doing a really good job. One of our residency programs, they do make their residents shadow physical therapy.
I like that.
I love that because again, like in my career outside of them, I have had one surgeon who shadowed me, and it happened to like he was co-treating the patient with me, and he happened to come in and just like sat through my,
Mm.
but I still appreciated it because like I did certain things and he asked questions about why I did things certain way, or like why there's a certain exercise that he really likes that I don't like, and he asked me why I don't like it, and we actually got to have a conversation about it while treating a patient when again like we all have limited time, that back and forth outside of work hours can't always happen.
Mm.
uh, so there's my hot take, is that more
I love that.
doctors and training should be,
Yeah.
especially if you work in conjunction with rehab providers,
Mhm.
you should be shadowing your rehab providers.
I love it. And like it sounds like a very symbiotic relationship when you guys are like under the same roof and in the same system. There's a lot better understanding. Me in the private sector, I get some wacky comments like, and it's always telephone. It's like my surgeon or whatever, my ortho told me to like never bend down ever again. And like right, between them seeing that person and seeing me, like, there were 2 years of misinformation and fear avoidance and all of these crazy things. I was like, "Let's nip that in the butt right now, touch your toes." Like, you know what I mean? Like, it's crazy that people, you end up you wanna trust your provider that's giving you, like, the best possible information for you, and a lot of the times, it's the goal is to, like, reduce risk more than anything else. So it's like, hey, if bending forward hurts, just like don't do that. And you're like, not the greatest answer, but like I can be, sympathetic from where you're coming from to your point if you only have 5 minutes to talk with them. Um, so from there, like in my world, there's a lot more like I like the term myth busting, but I'm like, it always feels like I'm contradicting. It's like, yeah, I know your doctor who you trusted or respect told you this, but I'm telling you something different. So how do you go about having that conversation where like everyone's on the same team and there's no like animosity?
I feel like I still struggle with what is the right way to approach that. Like, at what point do I feel like it's my responsibility to have a conversation with the provider of like, hey, I'm seeing I haven't done this yet. This is just like brain thoughts of like, I'm seeing a lot of your patients where they're telling me one thing and I'm telling them another thing, and it seems like this is a little bit of like a pressure point. Can we work this out so that we're on the same page? I think if you are in a hospital setting where you have easier access to communication with providers and you're like getting referrals from the same providers a lot, that probably should happen. Um, Private, it's really hard, but I kind of would recommend the same thing. If you're pretty regularly getting referrals from the same provider and you're like hearing the same thing from patients who see that provider,
Mhm.
that's what I would recommend, is like maybe at that point just like try to get on a phone call with them.
Mhm.
If it's something that like um that I haven't seen worked with them as much. And also just like in that moment, my job is to try to like just de-escalate stress, right? Because the patient is now stressed, but you're telling me one thing and my doctor telling me another. I had this situation. I have it not infrequently. I had it recently with a kid who had like an orthopedic ORIF. And surgeon was telling them that they could run. I was telling them that based on my measurements, nowhere near ready to run. Could not do a single leg squat on the surgical side. And so, and like, then this is an extra layer of complexity because it's a minor. And so parents are
Mm.
involved. And if anyone is going to get more concerned about two people giving different pieces of advice, it is going to be parents of a patient. I fully relate to now as a bit of a parent myself. I get it because I find myself questioning things. And to me, the best way that I can like approach it is number one, try to get over any imposter syndrome and say like, okay, they're an expert in their field, I'm an expert in my field. And so like my opinion, like I need to believe that my opinion matters just as much as the other providers, or else the patient certainly isn't going to believe it, right? If my primary care told me one thing, but my cardiologist told me another thing, I'm probably gonna believe my cardiologist a little bit more because they're the expert in a specific thing. So if it's like a rehab related clearing for activity thing, we should be kind of the final, again, both parents have to agree, but like we should be the final say because I'm worried about body performance. And like, if you do this thing, are you going to be at risk for re-injuring or injuring something else? And so for me, again, in this specific situation, it's about educating, like, yes, from like your repeat imaging that you've had, your healing is going really great. They think that at this phase of healing, you are ready to run. I'm looking at something a little bit different. I'm looking at is their body ready to run? And so I straight up like show the parent, like, this is a criteria that I have for return, like starting running around. And like running around your backyard, sure, a little bit different, but in terms of like getting geared up to do like a running progression, to do a return to sport type progression, and like I will show them like, hey, look at this leg, and this is the non-surgical leg, and then look at that leg. Do you see how different that is? Can you imagine if you're running with that level of difference, especially running being like repetitive and for a long time? Like that's not going to bode well. So we have to focus on this part first. Everyone's goal is to get this patient returning to run, returning to sport. That's my goal too. I want to do it safely. And from what I'm looking at, just again, like surgeon of the x-rays to see if they can recommend if it's safe, I'm doing this test to see if I can also recommend that it's safe. And I think that's the best way that like I can handle it. Like throw myself under the bus a little bit of like, I don't know. I can't give you the clearance from the orthopedic side, or I can't give you the restriction from like the surgical side, but I can tell you what I'm seeing and like what my education tells me. And then patient can make an informed decision.
Music to my ears.
Yeah.
And I totally agree with you. There's from a physician, it's a lot more black and white, which is why it seems like people are like, oh, but my physician said whatever. It's like, hey, bone was not attached to muscle. Now bone is attached to muscle. Like, we're good. And it's like,
Yeah, they did the surgery. They
yeah, exactly. And then you take them and you're like, okay, like if you want to be ready to run, you have to use single leg squat, hop test, whatever your criteria is. And it's like, I'm telling you, like, this is your test to, pass that. And it's like, if you can't pass the test, we're not running. It's very simple. So like that gives them the ability to like, it's like, hey, I know like I should be here and I'm not. So it's like, okay, like it's like it's like, oh, I know that I have to put in more work or take more time or whatever the case is, versus being like dad said yes, mom said no. And it's like an opinion based thing. It's more like concrete. They're able to grasp it a lot better.
thing, no, right?
Yes,
Yeah. So I think like if we're following that up with a plan, that also helps concern, because otherwise you're just hearing, I'm not ready. It's like, yeah, you're not ready, but like this is a really easy thing for us to work on. We just have to spend a little bit more time on this. This is our plan to get you to run. And I do that so frequently. I'm like, okay, I'm telling you that I don't think you're ready to get back on the field yet. This is why, and this is what I need to see you be able to do. You need to be able to do your single leg squats and also, your muscle testing at X percentage. You need to be able to do your hop testing. We need to then go through all of the progression of sprinting, cutting, change of direction, all of those things, to all the components of your sport to then get you back to your sport. And then they're like, oh shoot, that is like a lot of steps. Like I get it now.
Yeah.
I also like to put this in the perspective of like chronic pain patients, because that's the other end of the population of that. I see a lot. And same thing of doing, again, kind of myth busting, but this is where I feel like words matter almost more. Is the way that I word it is healthcare as a whole, like we used to think we know a lot more than we did in terms of like causes of pain. And people get it. I think, I know that you guys have kind of touched on this before, but like relating imaging to your pain. Is your thing the thing that's causing your pain? Yes or no? Is it going to heal? A lot of people get really stuck on like, okay, well, I have a disc bulge. Like, is that going to heal? It needs to heal in order for me to be okay. And so doing a lot of talking about like, okay, well, I know you've talked about this, Bruno, like talking about like people who have a disc bulge, have pain, have a disc bulge, don't have pain, have clear findings, have pain, have clear findings, don't have pain. I use that analogy all the time. And I'd also follow it up with like, this is not to dismiss your pain. Like you have pain, you also have findings. It doesn't mean that it's not creating it. I just like to use it to kind of like take down, again, it's all like de-escalating the stress associated with injuries. And also like, okay, sometimes it's heal, sometimes they don't. But like you could have been walking around with this for a long time and not known it. Versus again at other providers being like, well, you have this thing and that's what's causing your symptoms, and like we need to do XYZ about it.
100%. It's definitely a slippery slope when people get like attached to one thing. I feel like it's something that I should tattoo on my forehead. It's like pain is complex, like is
multifactorial.
Is the disc a factor? Maybe not. Like, and if I was being very blunt with clients, it's like it's like I have a disc bulge and I'd sit there and be like, and like, what's your point? Like, does it matter? Can you still do the things that you want to do? Like, there's so many other things that go into it that almost being like dismissive of the physical quote unquote diagnosis is something that, especially when I see a lot more like chronic pain type of people, it's like, I have a disc bulge and like, that's why I can't. It's like, that's where I go myth busting. And I'm like, okay, like we have to do it a little gently because they've held on this belief for however 20 years or something.
Yeah.
Well, it's like, okay, like I'm not going to tell you you're wrong, but let's do stuff and I'll prove you're wrong.
Yes. And it's a hard balance because I do think that there is a psychological component to, oh, my provider's not freaking out about this, maybe I shouldn't. But you also have to find the balance between that and like staying calm and reassuring versus, oh, they're dismissing my pain, because like it's just such a like. So again, it comes from not you, me, any one of us specifically, the system of like patients all over are feeling like they are medically gaslit, dismissed. Things are not found until later, diagnosed until later. And so I personally, I also just feel like as an empath, like I have a hard time being like, I almost feel like I almost over-explain of like, your pain is real. Like, you're not crazy. This is not in your head. Your pain is so real. It's just like, I try to throw myself under the bus of like, we just don't know as much about pain as we thought we did. Like we in some ways we know a lot more, but the knowing more kind of means that we know less because we don't have things to pinpoint your pain on anymore. It's so multifactorial. And that's kind of hard to hear because everyone wants it's not like it was doctors or we're doing anything like ill will by telling people, oh, it's your disc bulge and that's what hurts or anything like that. Like we want to tell people there's a thing that we can identify and like fix and do something about. And unfortunately, sometimes we can't, like it doesn't always work that way, or there's not going to be this like instantly gratifying thing. Or the same thing when I have doctors who refer people for like a specific, like they specifically put like McKenzie method or something on their referral, and the patient comes in asking for that specifically. I'm like, well, we might use components of that, but again, doing that like education work of, but actually like the more recent research is showing that there is no one specific method that like is the best for treating back pain. And really, like, I might use some techniques from it. We might, if that works for you, we might use some of those movements, but I'm not going to just do it because that's what people with back pain need.
I love it. I love it. Then, like, to your point where if we did have something to blame and someone did want to take that easy route, it's like, oh, let's blame the disc bulge. Great. Maybe that is the case in less than 10% of people, but then you get the 90+% of people who you blame the disc bulge, you do the disc surgery or the injection or whatever, and they come out of that on the other side and they don't have any resolution. They're like, okay, now I'm really confused.
Yeah, I'm going to give you the research too on like I've quoted before where it was in shoulders. They actually did it in fractures in the back from falls. I'm forgetting what they're called, but like they did the regular surgery. I forget what they inject to like help solidify the fracture after you fall to help stabilize it. But then they also did a sham surgery where they just went in, like tapped the bone 7 times, came out, and both groups had the same results. So that's a straight up, that's a real art. Can't believe how the hell that got approved. Like, who the hell?
We'll say that.
It was in Europe. There's crazy Europe here. But that's part of it where on the surgery side, it really does get interesting on like how surgery can affect pain, or maybe it doesn't do anything for you, right? And that goes back to pain is so complex that like even the imaging can spin you through a loop.
It depends. Oh boy. I think that's a good place to wrap it. Kathleen, we appreciate you coming on. And I don't know if you've been listening to recent episodes, but we have the guests give us their best. Go fix yourself. So take us out. Give it your best shot.
Oh gosh.